Hi everyone, welcome. Today our seminar series speaker will be Jessica Richardson. She's an associate professor and speech language pathologist in the Department of Speech and Hearing Sciences at the University of New Mexico. She graduated with a bachelor's in communication sciences and disorders and a master's in speech and hearing science. She then completed her PhD study at the University of Georgia and went on to complete a postdoctoral fellowship at the University of South Carolina. Her research interests include treatment outcomes and translational neuroscience, with an emphasis on adults with communication disorders following acquired brain injury. Dr. Richardson's research focuses on brain injury recovery and neuroplasticity, the development of aphasia treatment approaches, and the development of outcome measures that better predict increased life participation post-injury. So I'll pass it over to you, Jessica.
All right. Hello, everyone. Thank you for the introduction. I am happy to be here. Can everyone hear me okay? I just saw a note where someone said you're mute, and I didn't know if volume was working okay for everyone. I'm seeing nods. Okay. Well, I'm going to talk today about some work that I've been doing for several years now, and most recently have been funded for a multi-site project and shifting a focus where most of my funded work to date has been with post-stroke aphasia, but this work is with primary progressive aphasia. But involving a lot of the science and the techniques and my clinical knowledge and my research expertise in this population as well. One of the things I wanted to get a gauge on before I start talking too much is how familiar folks here are with PPA. I'm assuming there is some familiarity and not none, but maybe not everyone in the room is an expert in PPA. If you could just kind of write in the chat box, perhaps how familiar you are with primary progressive aphasia. That will determine how quickly I go through a certain set of slides. Okay, very familiar, evaluated but not treated. Keep them coming. Comfortable as a clinician.
Also, Jessica, we have several of our stroke survivors also attending this. So
Okay. So what I probably will do is keep some of the slides where I'm giving some basics about primary progressive aphasia, because that is generally what I encounter when I'm out giving all kinds of talks, is that I do have some people who are very familiar with it, but some people who just aren't quite sure what we mean by primary progressive aphasia. And if I need to slow down at any point during these introductory slides on PPA, please let me know. All right, so the title is Toward Precision Neurorehabilitation and Primary Progressive Aphasia, Lessons from Review, Modeling, and Remote Intervention. And let me try to get things working. Things aren't wanting to work right now. So again, this is a PPA crash course, but aphasia is something we're all pretty much more comfortable with, an acquired disorder of language, usually caused by stroke that affects reception and production of language across all modalities. Progressive aphasia first began to be described back in the 1800s, and sometimes it was described as part of a dementia or Alzheimer's process, sometimes as a specific subtype. So we have lots of different ways that this word, this phrase, progressive aphasia, was used when it first appeared in the late 1800s. But what did happen more so in the late 1900s is it began to be more recognized that people could have progressive language difficulty without progression of any challenges or difficulties in other domains, at least at the very beginning. And this began to be characterized more and more until consensus diagnosis and consensus definitions were reached in 2011. And this is where, as a field, we were introduced to, okay, now, how do I identify this? How do we diagnose this? And we're still working on even refining that consensus set of definitions and criteria, and still very much so needing to know how to treat it. And that's part of what I'm talking about today. Again, as part of this crash course, I have some pictures of some brains that kind of show also why it seems that the language abilities are targeted first in this progressive brain atrophy process. And that is because in primary progressive aphasia, the left hemisphere language areas are targeted by whatever underlying cause of the atrophy is in the left hemisphere, and not to the same degree in the right hemisphere. And that is why we have these language signs that show up early and more prominently. Initially, it was a unified diagnosis where it was just progressive aphasia, and there were attempts to categorize it like stroke-induced aphasias, first into fluent and non-fluent, then into subtypes. And this is what they tried to do. They tried to pop it on the usual classification onto it, and it just doesn't work. The classifications that we're more comfortable with of aphasia are more closely linked to cerebrovascular disorders or vasculature. And so it's not applicable to the patterns of atrophy that we see in primary progressive aphasia. In 2011, the criteria for diagnosis of PPA really set out that it had to be the most prominent clinical feature, had to be aphasia, that difficulty with language, had to be the principal cause of impaired daily living activities, and aphasia should be the most prominent deficit at symptom onset and for the initial phases of the disease. And this is something we talk about a lot in disease management, is this initial phases of the disease is very important to consider, because it matters then when you're seeing this person, when they get to you, and how far they have progressed in terms of how prominent that language issue is going to be relative to other things that might start to be developing. Cognitive issues might start to be developing. Motor issues might start to be developing. So the phase of the disease as part of this definition really matters as well. There are also exclusion criteria that must be answered negatively. It can't be accounted for by some other non-degenerative nervous system or medical disorder. It can't be better accounted for by a psychiatric diagnosis. And if they do have more prominent and initial problems with memory, or visual perceptual problems, then it's not primary progressive aphasia. They might have aphasia, they might have language problems, but it's not primary progressive aphasia. And the same with this prominent initial behavioral disturbance. We have some kind of patterns of seeds of atrophy that we're learning more about as well, with the different subtypes that we now know of for PPA. And I'm going to a slide quickly. The three most are going to be the non-fluent agrammatic variant of PPA, and you're not expected to read all of this little text here to see how we diagnose that. But you can refer to this and its seminal document that defines this later. The diagnostic features of semantic variant and also the diagnostic features of logopenic variant. Over the years, though, we also have recognized that there are some people who might be categorized as this non-fluent variant, but really are almost purely apraxia of speech, that they're not really showing the agrammatism. They really have a progressive apraxia of speech. And this is where we also have more information coming out now from various labs showing that, okay, well, we need to kind of think about this group separately. Their seed of atrophy also is a little bit different, though there is some overlap with the seed of atrophy for this larger non-fluent agrammatic group. And so these circles are meant to kind of show you that, is that this is where atrophy, if you can see my cursor now, tends to start for logopenic variant PPA. Up here in the anterior temporal lobe is where it tends to start for semantic variant. In the IFG and the premotor areas and the motor areas, and also some of the supplementary motor areas. This is where the seed usually starts for non-fluent agrammatic. And the seed for PPAOS is more thought to be more so in the supplementary motor area. So this is information that about where the atrophy kind of begins. And of course, it spreads as the disease progresses for PPA. An important point that I want to emphasize here is that there are many paths to PPA. And this is where it's very, very difficult in terms of counseling and education when we're, trying to explain this diagnosis. And even we're trying to explain it to providers about what PPA is, because really PPA can be a subtype of an Alzheimer's disease. So you can have a language-led Alzheimer's disease etiology, and that can be a primary progressive aphasia. The one that was more understood and better characterized even before the official diagnosis was the language variant of FTD. So for a long time, we've known that there was a behavioral variant and then more a language variant of frontotemporal dementias. And this language variant of FTD would be a PPA. But we also have case studies of this occurring because of vascular cognitive impairment or people with mixed profiles, for example, who have vascular cognitive impairment and Alzheimer's disease. We've seen PPA associated with Lewy body dementia and other profiles. So what we're calling PPA can happen because of different underlying neurodegenerative profiles or etiologies. And that can be very difficult to explain to providers and patients and their families. I want to talk a little bit about PPA and treatment. Here's a great quote from one of my neurologists here in Albuquerque that I love to share with everyone, and I'll just read it straight out. Dementias with prominent aphasia, such as PPA, tend to progress relatively slowly. So people with PPA have time to incorporate and benefit from behavioral treatments and/or compensatory techniques to maintain communication. And then another quote from my colleague, Henry, in a paper on treatment, says healthcare providers should consider all speech language treatment as a necessary component. And I kind of have a question mark here. What type of care are we talking about? We're not just talking about trying to introduce AAC. We're not just trying to jump to the end and talk about counseling and palliative care, but also prophylactic and restitutive approaches, compensatory approaches, including assistive technology and partner-focused interventions. The same smorgasbord of options that we would offer to people who had a more stable presentation of aphasia due to a stroke or other brain injury. But there's some challenges and barriers here, and I have it listed here, and I'm sorry it's showing the typo there, but patients and families, we know, and you guys have probably experienced this firsthand, they seek options for treatment right away and often desperately to try to maximize communication and quality of life. And very often they hit a wall. Nobody knows how to help them, where to send them. And I can be helpful with resources to try to point people towards as well. If you guys are in need of that, to tell people when they do contact you, seeking help and seeking options. And many individuals with PPA are still not referred for speech language treatment. I think probably your experience is similar to what my experience is that most of the time they're monitored. They're tested yearly, maybe twice yearly, but most of the time it's a monitoring situation. And very rarely are they actually referred for speech language treatment for treatment. Usually it's for diagnosis, but not necessarily treatment. And there's also just lack of knowledge on behalf of SLPs, but all providers on what we do for people with primary progressive aphasia, and definitely lack of knowledge and pessimism on behalf of third-party reimbursers. However, there's been enough research and reviews by now that are really showing that treatment can be very effective for people with PPA. In this study, there were about 126 treatment studies identified. Overall, it supported that people with PPA and primary progressive apraxia of speech, or PPAOS, can improve following speech and language treatment, especially lexical retrieval treatment. There were limitations that were pointed out in this and in other reviews. There's a need for more rigorous designs. There's limited evidence beyond lexical retrieval treatment. It just was the one that was most studied and most investigated in the review. There is a need for interventions that take into account progression over time, evolving clinical profiles, and of the neuromodulation studies that were reviewed and that were able to be reviewed at the time, they lacked rigor, and they were not grounded in the neurobiology of PPA. This is another slide I'm going to show you that has a whole bunch of work that I've been doing that somehow relate to assessment or treatment in PPA. And oftentimes I just have to show this just for people who know me from the stroke world to kind of provide a rationale as for why in the world I'm here talking about PPA. But this is just to kind of establish also that the things that I'm interested in have been related to better measurement of outcomes, including using discourse to measure outcomes, also using neuromodulation in people with PPA. And those are some of the publications. And then there's even more conference presentations that are related to those same topics, but also other things such as group treatments. We've done group phonological treatments. We've done virtual reading groups with people with PPA. I run a choir for people with all types of neurological injuries and disease, and we have a sub-study on people with PPA and how they've engaged in choir and whether or not improve their outcomes as well. So a wide range of topics that I study as it relates to people who have primary progressive aphasia. All right, so that was kind of the crash course in what is PPA and why are we talking about treatment and PPA? And you know, the basic statement that I can make, the most basic statement that I can make is that treatment works. Just as in aphasia, we don't always know the details of it. We still have much to learn about which treatment and for whom and at what schedule and all of that. But there is enough evidence that's showing that, hey, don't just ignore these people. Don't just monitor these people to see how they're declining over the years. Let's talk treatment. Let's talk about ways to help them because there is still time for you to help them. So this is where I start talking also about tDCS. And so tDCS is type of transcranial stimulation, and this is called transcranial direct current stimulation. And the reason I bring up tDCS is because thinking also about, you know, the time frame that people with PPA are dealing with. We know progression is on the horizon. We know that treatment can be effective. Is there a way that we can make it more effective, more potent? And one of the ways that I think that we can do that is with tDCS. There have been some meta-analyses that show that tDCS is safe and feasible in PPA and may enhance treatment outcomes. But if you're familiar at all with this literature, you can kind of see immediately that the rigor and the transparency of how these studies are being done leaves much to be desired. And in my lab's recognition of the fact that the research in the field is severely lacking rigor, and in response to one article that was a little misleading about how we should handle modeling and current flow and dosage in people with PPA, we set out to kind of improve the state of the field by really looking at it very closely. And that's where the review portion of this talk comes in. And you can actually, I'll share these slides with you guys, but this is a registered project we have on OSF, on Open Science Framework, where we've registered our review and our simulation study that goes with it, and we'll put all of our findings and all of our products there as well. So this is just kind of going through the workflow for that. From 532 identified articles, 40 met inclusion. So you can see that down here, how many we included. They were included if they used tDCS, and the participant sample included people with PPA. We didn't, of course, go after articles that were inaccessible. We didn't include dissertations, abstracts, things of that nature. But this is kind of showing you the process of how we got down to the 40 articles that we included in our review. And this is just a summary, just a kind of a high level summary of some things that we found. First, just about electrode placement. We found that within these 40 studies, there were 32 unique montage configurations, and only 4 were repeated across studies. And the 4 that were repeated were placed at the left inferior frontal gyrus, around the EEG electrode of F7, and the right cheek. And then the left DLPFC, a little bit forward there at F3, and the right arm, or the deltoid. The left IFG again, and the left occipital, so staying in the left hemisphere. And then the left parietal and the right supraorbital. So I don't know, you saw me touching my head and my arm while I was going over those. So a lot of variability, not a whole lot of things repeated across studies. And what you'll also learn is that there wasn't a lot of explanation or justification as to why these montages were selected, why these electrodes were placed where they were. Electrode sizes, for the most part, they were the 5x5 electrodes. Some used 5x7. There were other sizes there as well in 3 of the studies. 5 of the studies did not report their electrode sizes. For scalp dosage, the most common was 2 milliamps. Beneath that, in 8 studies, was 1.5. And then 1 study used 1 milliamp. And then there was some variability where some studies used multiple scalp dosages. And some of them even used it up to 5 milliamps. tDCS duration, 20 minutes was the most common, followed by 30 minutes, and then other. The number of sessions that they had was highly variable. So it really kind of depended if they were looking, at just a couple of days, to some people were just doing, a comparison of 1 week of active versus 1 week of sham, versus, longer treatment schedules. So highly variable in terms of the number of treatment sessions that people participated in with tDCS. Out of the 40 studies, 34 also administered a behavioral treatment, and the type of treatment was highly variable. So for the most part, though, the tDCS was administered concurrently with the behavioral treatment, which is the general recommendation when you're thinking about the mechanism for tDCS. Very few studies reported any sort of region of interest for their target, and the targets varied greatly. And 13 studies provided some sort of electric field model of the stimulation. So they simulated what the neuromodulation or the neurostimulation would look like. But I will make this point later as well. A lot of these were recycled. So there were, several studies that used the model from the paper, 5 years prior. And so what we reviewed, and in the paper that we're publishing on this, we go into detail on all of these things that we're finding. And then what we also did was we simulated. So we took people from our database with PPA and their brain images, and then we modeled what these montages would be on these people with PPA. So we could also get a better sense, and especially because the papers themselves aren't really providing this information about what is going on with this current when people are getting brain stimulation. So we wanted to provide that information on a sample of people with PPA. So we really sought to model these main four, the montages that were repeated across studies. However, we could not do the arm deltoid model because in our scans, we don't scan below the neck. And so we replaced it with another one that is becoming more commonly used and more talked about and explored. And that is this IFG superorbital. So instead of doing the left DLPFC right arm deltoid, we did the F7 in cheek, P3 and superorbital, and then we added this frontal. By the time we publish this, we'll have 6 in each of these columns. But at the time of this presentation, we modeled 4 controls, 5 people with LV PPA, that's logopenic variant, 6 people with non-fluent variant, aromatic PPA, and 6 people with semantic variant PPA. And the good thing about the brains of people with PPA is that a lot of the pipelines that work well with controls still work really well for people with primary progressive aphasia. Oh, I'm so sorry. Is it really bad?
Not too
I'm gonna
bad.
turn
It's
off my
just
video
in
so
bits and
maybe you can
pieces,
hear
but
me.
if you can turn off the camera, I think that will be helpful.
Okay.
Thank you.
Yeah, so sorry about that. So again, the good news is that a lot of our pipelines work really well. I mean, it could be also because of my lab is very specialized to be able to do this modeling and simulating. But we are able to use SimNibs and the tools that is within SimNibs to be able to produce a lot of our models. And so we ran these simulations in SimNibs and we pulled out all of these E-field metrics. We're looking at the magnitude of the electric field and where the peaks and where the highest values are in what ROIs. And we use the Brainatome Atlas to find those neuroanatomical references. So I'm going to go over a few pictures just to kind of let you know what we see. And this is just a simulation that shows cortical dosage and E-field distribution. And we've only chosen the person who had the lowest magnitude of E-field and the highest magnitude of E-field, just to kind of show them to you side by side. And so for on your left, you're seeing montage 1, which is F7 and the right cheek. And you're seeing the person with the lowest magnitude on the left and the highest magnitude on the right. And then on montage 2 on your right, you're seeing F7 and the occipital lobe, and you see the person with the lowest magnitude on the left and the highest magnitude of the E-field current on the right. And so there are a couple of things that just with visual inspection that I just kind of want to point out. One is like, for example, and again, these are all people with PPA. For these pictures, we weren't showing you how they related to controls, though I do show you that with numbers in a table shortly. But you can see immediately that, for example, there's a peak on this person here that you can see. I think my cursor is on, but you don't see a peak for that person, for that same person with the same montage. You don't see the same distribution and the same peak for that person. And so that's, kind of an immediate thing that jumps out at you from this picture. You've also got more temporal lobe activity here on the person on the left and less so on the person on the right. This person on the left is a non-fluent variant PPA, and this person on the right is a semantic variant PPA. And part of the reason we're probably seeing differences in the overall E-field distribution is because their patterns of atrophy, their seeds of atrophy and their patterns of atrophy are going to differ. And the reason this is important to think about and consider is that a lot of these studies that we reviewed up here are applying the same montage to different types of PPA. So they're enrolling people with PPA, they have different variants, but they're giving them oftentimes the same scalp montage. Over here, you also see, for example, This person who is a semantic, both of these are semantic variant, but this person has a little bit of a peak here that overlaps with this person, but the magnitude of the electric current that the person on the right is experiencing is way more than the person on the left is experiencing. And so even though, and this is critical, even though at the scalp, their dosage is the same, the electrodes are in the same place, they're getting the same amount of current pumped in through their skull, you can see that their cortical dose is different. And this is something that we have to start thinking about as we're doing neuromodulation research, not just in PPA, but in all areas, especially if it involves brain injury or disease. This slide is showing you a similar thing, but with different montages. So montage 3 was P3 and the right supraorbital, and montage 4 is F7 and the right supraorbital. And what you can see is a big difference in this, a person with non-fluent variant and this person with semantic variant in terms of their overall magnitude. And you also see differences in this person, their peaks are more here at the around the pre and post central area, whereas this person's peaks are involve a little bit of that, but a lot more in the temporal and parietal areas. So the distribution overall, as well as where the peaks are landing, are quite different. The other thing that I want to point out, the last thing that I want to point out, just visually on these, is that so often we are focusing our conversations on what's going on under the electrode, and we're completely ignoring all of this other magnitude of current that is happening elsewhere in the brain. And even when you're trying to do things to minimize that, for example, this montage that is trying to have it on the cheek instead of on the head, you're still seeing that there's a lot of activity on the other side of the brain as that current is headed over to that cheek. So even those attempts at really trying to minimize that what's happening under the reference electrode are not as effective as we're thinking. And the same is true for those that go on the arm. What we have simulated a couple of them on the arm and even on the neck, because some people are putting it on the neck in other studies. And what you are seeing is that you do get a little more focused under the anode electrode or under the electrode where you're trying to, really excite things. But what's happening as it's traveling to the arm is it's kind of going down in the cerebellum and then the brainstem to try to get out of that aperture, that foramen there. And so you're actually getting, a lot of stimulation where you had no intention, you did not plan to get it there at all. And this is something that we're going to have to think about when we're inferring more and more about tDCS and when we have better models for them. So just visually, that's what I wanted to point out. And then we produce a lot of tables, and I'm not going to put them all here, but I do just want to highlight a couple for you. And what we did is we looked to see, okay, what were the ROIs that had the greatest magnitude of E field? And we were also looking at like E field in a certain direction as well. It's called E normal. But what were the ROIs in the left hemisphere and the right hemisphere with these different montages? And were they the same? And this is important, again, thinking about the dose, because, we saw that the spatial distribution was quite different. And now we're looking at the spatial distribution and also the numbers that relate to these differences in heat maps, right? Differences in this scale here. And so we found for controls with montage 1, which, just for a reminder, that was F7 in the right cheek, the ROIs with the greatest magnitude of current was the frontal lobe, the orbital gyrus, and the IFG. And these are all Brainatome Atlas designations here. And you can see this is the value. This is a mean of 0.17 volts per meter. This is just linked to how many volts you get in the cortex if you get 1 milliamp at the scalp. And so if you were getting 2 milliamps, you would just double this. In LV-PPA, you can see one of the maps is the same, but then they also had a lot of E-field in the parahippocampus. In non-fluent variant, it was, again, some similarity in one of the maps, but also similar to LV-PPA, you had this parahippocampal area, and the SV-PPA looked more like the control. And so, but you can see the values here were much lower for the people with PPA compared to the overall values for the controls. So what we're seeing is that, okay, they're getting the same scalp dosage, but they're not getting peaks in the same area all the time. And their cortical dosage, we have some similarities with PPA, but it differs quite a bit from control, which is consistent with the Unal paper that where he simulated some brains of each variant. We also looked, just to make sure that we educated everyone on this and beat this drum, we also looked to see, okay, well, what's going on in the right hemisphere? So we're most focused on the left hemisphere, but there's an electrode for the most part over there as well. We need to pay attention to where the peaks are on the other side, and specifically what the dosage is on the other side as well. So even though you're not targeting left hemisphere areas with these montages, even though you're not targeting right hemisphere areas, you still have current going there, and it is current that is of a similar magnitude as what you are focused on, which is under the anode. And so we have lots of tables that really kind of emphasize this. And really the take-home message from our review and from the simulation that we did was we really need more work that emphasizes individualized targeting approaches. And so that's what a lot of my work now is focused on. Not only can we make it more effective and more potent, can we also do it in a way that people all over the United States can access? And this is where remotely supervised tDCS comes in. And so I did the first feasibility study of remotely supervised tDCS in either aphasia or primary progressive aphasia. We included both people in that study. And we were able to show that people with aphasia, with the proper training and the proper protocols, were able to administer tDCS to themselves at home if they were supervised via teleconference. And this is really exciting because it does increase the accessibility of tDCS studies and may also allow us to enroll larger sample sizes for clinical trials. We set out with another study to show feasibility and acceptability of a clinical trial protocol that combined remotely supervised tDCS with established telerehabilitation procedures. And this is with my colleagues at UT Austin and at UCSF. And we enrolled 9 people with PPA or PPAOS and their study partners, 2 with LV, 2 with SV, 3 with NFV, and 2 with a more purely AOS profile. And at the time, we were doing crossover studies and trying to make sense of crossover studies. It's actually something that I don't necessarily recommend for PPA really anymore after recent recommendations and meta-analyses, but also our own experience. The people with logopenic and semantic variants received this lexical retrieval cascade treatment, which again is the most studied in the PPA treatment literature. And then people with NFV, PPA, and PPAOS received something called VISTA, which involves looking at a mouth model who's saying a script and kind of following along with that mouth model. And those are the 2 virtually delivered treatments that they received while they were also being administered remotely supervised tDCS. And we had different stimulation sites for each variant. And this is really based upon research that showed where it made most sense based upon their treatment responsiveness in other studies. And so for semantic variant, their response to treatment in other treatment studies was really predicted by left hippocampal, left supramarginal, and angular gyri. And with logopenic, it was predicted by middle and inferior frontal gyri in both hemispheres. And with Vista, it was left supramarginal, middle temporal, left middle temporal gyral area. And so we had a different location for each of these montages based upon their neurobiology. We do have this information available in abstract form right now, and we are submitting the paper. I think the draft was just finalized last week. So this information should be coming out in more detail pretty soon. But just briefly, we did notice that this was feasible. 100% of our 9 participants passed pre-treatment assessment of competence with remotely supervised tDCS procedures, 89.5% both phases of treatment, 100% of planned sessions were completed, 100% retention for follow-up assessment, no severe or intolerable side effects, 100% fidelity to language therapy steps, and 99.4% of planned outcome measures were completed. So in terms of a feasibility of this type of study for people with primary progressive aphasia, we're getting a thumbs up there. Acceptability and demand, we administered a survey that asked them to, answer all these questions about if it was easy to follow, if it was easy to do, if they would recommend it, things like that. So some of the questions you see are, I enjoyed giving brain stimulation to myself. I enjoyed getting instructions through video conferencing. Again, this was easy to follow. I would feel safe doing it at home. I prefer to do it at home. And so all of these are telling us that people can do this and they feel comfortable doing it at home, and they feel safe doing it at home. And this goes along with this too. When you ask them, I would be able to do more brain stimulation sessions if they were held at home. Most of them say, yeah, like if I can do this when I'm at home. If I have to go into a lab to do it, it makes it a lot harder. We have that accessibility issue. So our results confirm the feasibility of the remotely supervised tDCS clinical trial protocol, and also support the acceptability and demand. We had some preliminary outcomes that supported that response to treatment could be enhanced during active stimulation. We had a lot of inter-individual variability in response to tDCS. We were also looking at the appropriateness of the outcome measures, and we were looking at a lot of connected speech measures. And we did find that some connected speech measures appear to be potentially sensitive to change in active versus sham conditions. We have a lot of recommendations in this, and also the review paper that's coming out, that using this pilot data and those recommendations, that larger scale clinical trials should be able to be proposed and to be successful based upon those recommendations. And so from that, we were able to use actually some of this pilot data to submit at the time it was called an RO1. With all the changes at NIH, they changed it to an RF1, which was new to me. So I'm still kind of learning about that mechanism. But my collaborator and the PI on the entire project, Maya Henry, myself, and also collaborators at UCSF, finally were successfully awarded this, investigating the benefits of remotely supervised neuromodulation in primary progressive aphasia. And the first aim is to evaluate the feasibility, acceptability, and preliminary benefit of remotely supervised tDCS with virtual speech language treatment in people with LV-PPA. So this first big trial is really focused on people with logopenic variant. And then aim 2 is to identify neural and electrical field factors that predict responsiveness to tDCS in PPA. And so they have pre-treatment, we fly them. And so some of this who are working with Swathi and Maria on this P50 grant will kind of recognize some of this design, is that they have to go somewhere to get scanned. We train them with the device, and then we send them home with materials, or we mail them their materials for treatment. And they do the behavioral speech language treatment with remotely supervised tDCS or sham stimulation. For this study, they do it 5 times a week for 1 month. And we look at post-treatment outcomes and 2-month follow-up. And this is not a washout. We can talk a little bit more about washout and why that may not be appropriate for this population for tDCS studies if we have time. And I'm going to try to wrap up. I know I'm running out of time. We do have to train them. So they get introduced to the equipment, they get shown how to put it on themselves. We make sure that we have steps in place to ensure that they're putting it on themselves in the same way each time so that we can have as much reliable placement as possible. And then they kind of have to take a test to make sure that they're able to do it. And we do this in-person training, and then we go into another room and we kind of do it virtually with them while they're still on site. So we can, kind of do any calibrating or retraining while we're there. We did select this frontal site here for the LVPPA based upon that research and treatment responsiveness. And so our electrode locations are here. We have it at FC5 and at FP2, and we're delivering tDCS at 2 milliamps for this trial. So this is what it kind of looks like. This is the tDCS, some headgear that they get sent home with. And then this is the clinician's view. So this bottom computer on the right is what the clinician is seeing while they're walking the participant and their study partner through the procedures. And then for outcomes, we're looking at measures of feasibility and acceptability. And that ranges from clinician training to intervention fidelity to headset placement, all the way to, making sure that everyone's completing their assessments. Preliminary efficacy, we're looking at naming accuracy and untrained naming, patient-reported outcomes, as well as connected speech variables. And then we're also looking at neural and electrical field predictors of treatment response, looking at what's going on with the E-field in the region of interest that we're targeting, global network E-field measures, and seeing how that relates to their response to the behavioral treatment. So that is kind of the broad overview of PPA and what's going on in my corner of that world right now. And we did actually make it into the end with a couple of minutes to spare for questions and suggestions.
That's awesome. Really good. Can I start with the first question, Jessica?
Yes, absolutely.
So I obviously really needed to hear this and understand how things work. So I think this is a more basic question because I'm trying to understand the methodology. So in a given patient with a given locus of diagnosis, how does the E-field modeling help with deciding where to target? Like, do you already know that you want to go in there and you're just sort of tweaking the parameters, or is it really helping you figure out where the location is?
Yeah, so this is a good question, and I'm probably going to expand it a little to answer a couple of questions. Can you guys hear me okay, or do I need to cut my video off?
No, it's fine.
Okay, I'll cut it off just in case. The modeling that we're using in that study is really just to make sure that we can characterize the E-field given the montage that they received and the doses that received, because we know it's going to be different for every single person. And that's kind of what I was trying to show you and convince you of when I showed you those other slides of where we simulated the montage that are in the literature on these different brains of people with PPA, is that there's so much variability for every person. And we do not yet have really any solid understanding of how cortical dosage and E-field variables as it relates to cortical dosage, how that predicts the treatment response. We also know nothing about how it interacts with what's going on in the brain because of the activities that they're engaging in. And so the modeling that we have as part of that study is really to be able to start to characterize that so that we can learn more about that through this study. What I have other studies, what we're trying to do, one of my R01s right now in stroke is we're actually using the modeling to change the montage. So in this study that I just presented to you, everyone with LVPPA is receiving the same montage. But in another study that I'm doing, people receive a different montage based upon their lesion location and what basically the solution that my modeling software provides for me. If I tell it, I want to hit this area of the brain with this amount of current, and here's their lesion and here's their brain, tell me where should I put their electrodes and tell me how much voltage I should put through them. So that's a different way to use modeling to get even more individualized and optimized. So this study is not doing it yet. That's a future direction. But we will learn a lot about e-field predictors, I think, as it relates to treatment response with this study that I just talked about.
Got it. And so just to make sure that everybody understands what you're trying to do here is you're taking tissue that you think is at risk or is starting to degenerate, and by stimulating it to the best of your knowledge and the best intensity, you're hoping that when you combine it with treatment, you're using what is residual and functional to improve.
Yeah, with this particular model, so again, there are different models, and a lot of the models that they started with PPA were really kind of pulling from the stroke literature. And a lot of times with the stroke literature, right, they're trying to target perilesional areas or, areas near the lesion. Or sometimes they'll, go away from that. But at least sometimes there's a rationale for why they've selected a certain approach. With PPA, there's not always the rationale. Our rationale is we're selecting a part of the brain that is actually more preserved in this variant in these people. So we're further away from the seat of atrophy. This is more preserved. And also in treatment research, it's the area that shows that it's most responsive in people who are responding to treatment. And so really basing our target selection on the neurobiology of that specific variant and on the intactness. And other people might take a different approach, but that's the approach for this study.
Yeah, got it. Thanks. I think you have an online question.
Let's see. Thanks for your talk. You showed 2 patients whose montage and current were the same, but the effect of cortical activation was significantly different. Could scalp thickness predict the activation, or are there other factors involved? This is a great question. And this is, again, like why we need to start paying attention to it. Scalp thickness is definitely one. How much atrophy is, so how much distance also there is between the scalp and the brain is another one. How much fluid you have in that brain. Scalp thickness is also directly related to male or female. And so, in that way, sex as a variable is important here as well. And just, how much atrophy they have, how far progressed they are, is another variable here as well. Good question. Any other questions?
I'm waiting for Shaz to ask this question, but she hasn't, so I'll ask it. Why only PPA? Why not something similar for MCI and other kinds of dementia? Like, can this, if the modulation works in certain parts of the brain, why can't we expand it to anybody who has any form of neurodegenerative disease?
Yeah, no, I think we should. I think we should do the research and quickly. People are going to start doing this in their home. They already are. They can figure out how to buy it or make it. There's even YouTube videos on how to build it yourself, right? But I want to make sure that that we do more rigorous research so that we have better guidelines to help them determine where these pads should go, what the schedule should be, what the dosage should be, all of that. But absolutely for MCI, for other types of PPA, for Parkinson's, I know that there's some study with Parkinson's as well. Lee Charvet has done several other studies where even with multiple sclerosis. And so there are definitely already other work being done in other populations that experience neurodegeneration, in addition to people who have acquired brain injury as well. And I think, this is until someone interrupts me, but I think there's a lot of promise for us. I think if we could hurry up and do rigorous research and figure out something about tDCS. There's other types of TES. So, transcranial electrical stimulation includes direct current, alternating current, random noise, other types. Now there's theta burst, there's oscillation, like there's other things that are coming out of the woodworks. And I think that, rigorous research so that you can actually do something and then infer something from it is critical for us to make any sort of progress is going to be helpful. And that's kind of the frustration with a lot of the tDCS research. And you can see it just from the visuals. Like, and I think even someone mentioned it in this talk, or maybe it was in my meeting earlier with Maria, but, saying that everyone's receiving the same dose in a study. No, they're not. They're receiving the same scalp dose, but their cortical dose is not the same at all. So, I don't want to devalue all of the work that is out there. A lot of it's mine as well, right? That's showing the promise of this. But we don't actually know anything about dosage as it relates to tDCS because there hasn't been a study to this date that has controlled cortical dosage.
I have a quick question, Jessica. This was wonderful. Thank you so much for a great talk. I think your research will perhaps answer this question years from now, but I was wondering just to pick your brain about whether you think that tDCS combined with behavioral intervention or would actually alter the disease trajectory in some of these neurodegenerative conditions, whether it would like slow the decline or alter the process.
Yeah, that's a really great question. It's something I've been kind of agonizing over. It's one of the reasons I actually kind of got a little delayed in using tDCS with PPA because I was actually worried, like, am I going to speed this up? Like, like if it's traveling along a seed of inflammation, or if it's traveling along a seed of, perfusion, like how is this atrophy traveling? So we're learning more about that. And I think we need to just be very, very aware and on top of whatever the research is coming out as it relates to perfusion and inflammation and how the atrophy spreads. But I do think, tDCS, there's links to changes in perfusion as well, that you can actually impact cerebral perfusion with tDCS. This may have, really important implications for people in the vascular cognitive impairment world, where, their degeneration is not set in stone. You can actually, pause that where it's at with the appropriate interventions, and they're not destined for the same type of degeneration. And that also has an immediate and direct link to people with stroke because, about a third of them might be candidates for that. So, looking at a perfusion angle, looking to see how it, especially as we're learning more about inflammation, looking more at that to see how tDCS interacts with that, I think is going to be very important as we apply this. But that is also why you see a lot of efforts, and even my early efforts, to keep electrodes off of the head whenever possible. Like the extracephalic on the arm or on the neck or on the cheek. But now that we model it, we actually see we're not really doing anybody any favors. They've got tons of cortical current, and they actually have current in places where you don't expect it to be, and maybe where you don't want it to be, just because it's being, shunted or traveling a path trying to get down to your arm. So, you know, now that we have modeling, we can learn more about that and understand that. But I think we've just always got to, every new development that comes out, trust me, I'm watching. I don't know if I answered your question though. Sorry about that.
Oh, you did. Thank you.
I think
All
G has
right.
a comment, but question, G, or was that a comment?
Oh, yeah, it was not a question, but I think, in terms of applying this method, the neuromodulations to other cognitive or the language disorders. So I think there are, somebody has mentioned that there is another like alternating current stimulation ACS by manipulating like emphagic and antiphagic stimulation methods. And for also, but the limitation of this current based cortex level stimulation is it's hard to get to the deep structures of the brain. So yes, another line of researchers have attempted to apply this TIS, like a temporal interference stimulation, using multiple currents going through in the deep structures that can be targeted with the hippocampus. So
Yeah.
there is another, trends of simulations for people with neurodegenerative disease with multiple, like a deep structure atrophy. That was just one quick comment. Yeah.
Yeah, there's new work coming out with the ultrasound as well, the transcranial ultrasound. Lots of stuff. And of course, you know, TMS, there's new stuff with accelerated schedules with TMS that's really promising. We're running a study right now using an accelerated schedule with TMS, and it's pretty mind-boggling how quickly we see change. So I had someone come up to me to say, you know, do you really believe in this? Or is this all snake oil at this point? Like, are we just selling something? And I'm like, I would not be spending my life studying this if I didn't believe it and if I, hadn't seen it like firsthand. But I understand where you're coming from, as a cynic, as a skeptic, because why don't we have more and better answers by now? And a lot of it is in our methodological choices that we have taken and have allowed the field to take to, to not dive in and answer that question in a way that needs to be answered, that is rigorous and reproducible.
Well,
So
let me end on on a positive version of what you just said,
yeah.
which is this work has the potential to be a game changer for a population that has nothing, that gets nothing other than a diagnosis that makes them scared about what's the future. And now there's actually data that's coming out that's saying you can actually make a difference. And yes, you need to hurry up and get good data out there, because everybody who's given this diagnosis wants something to hold on to. And if it meant doing this at home on a schedule that the doctor prescribed to them, isn't that amazing that they would actually be able to do this at home and do the therapy they think is helping them? So yeah, you need to hurry up and get the good data, and it has the potential to be a game changer.
Yeah. Yep, I agree.
Okay.
Yeah.
On that note.
Yeah. Well, thank you for having me. And I do want, everyone here on the call to be advocates for treatment in PPA. We still have so many people who just don't think that you can do anything or don't know what to do. But so help be an advocate for that, please. And thank you for the thumbs up and the claps.
Thank you.
All
All
right.
right. Thanks a lot. Bye. See you tomorrow. Yes.